we're going to talk about something that doesn't always make it to the top of the discharge instructions, but it should. Because once the stroke hits, the recovery isn't just about rehab. It's also about dodging every complication that's trying to sneak up on your patient while they're down. Strokes may be the headline, but the fine print, that's where complications live. And if we don't pay attention, that fine print can steal the whole story. Let's start with the basics. When someone has limited mobility, impaired swallowing, weakness, or altered awareness, the body's defenses are down. And that means things like pneumonia, pressure injuries, DVTs, and even depression can come creeping in if we're not careful. Let's talk skin. If a patient can't turn themselves, they're going to need help, and not just when we feel like it. Pressure injuries love a warm, quiet, bony spot. Heels, sacrum, hips, you name it. So we reposition every 2 hours, we get them off their backside, we use special mattresses and cushions, and we look at the skin. Not guess, not chart it from the hallway. Look at it. Hydration and nutrition matter too. Protein feeds skin. Water keeps it plump. So don't ignore that boost or that half-eaten tray. They're part of the wound care plan, whether there's a wound or not. Next up, breathing. Swallowing issues? That's your fast track to aspiration pneumonia, if we're not ahead of it. So nobody gets a tray without a proper swallow eval. And that head of bed? It stays up. All the way through meals and for 30 to 45 minutes after. If they sound gurgly, cough after sips, or suddenly spike a temp, get speech therapy and let the provider know. Aspiration is sneaky, and it doesn't always look dramatic at first. And while you're at it, encourage deep breaths and get that incentive spirometer in their hands like it's part of their therapy. Because it is. Let's not forget about clots. If your patient's lying in bed not moving one side, that's a recipe for a DVT. We want SCDs on, anticoagulants if ordered, and passive range of motion at minimum. Don't wait for swelling or calf pain. Prevention is your best friend here. Now let's talk about the big scary ones, like another stroke. That's right, one stroke increases the risk of another. So blood pressure needs to be controlled, medications need to be given on time, and lifestyle changes start before discharge. Smoking, diet, glucose. This isn't a later conversation. It's a now conversation. And then there's seizures. Not everyone will have one, but if they do, you'll see twitching, altered consciousness, or even just weird behavior or confusion. We keep the bed low, padding in place, and call the provider fast. Don't just chalk it up to stroke fog. What about the brain itself? Increased intracranial pressure can still happen, especially in hemorrhagic strokes or large infarcts. If you see a sudden change in consciousness, one pupil bigger than the other, new vomiting, or they just look off, don't wait. Raise the hub, check vitals, and escalate fast. The gut's next. Immobility slows everything down, and that includes the bowels. Constipation is common, especially with pain meds and dehydration. So get ahead of it. Hydration, stool softeners, fiber when appropriate. Monitor for distension, discomfort, and those famous hasn't gone in days reports. If they're not eating, dig deeper. Is it depression? Is it dysphagia? Is it just that hospital food is a culinary crime? Either way, loop in dietary, consider supplements, and don't forget to weigh them and track labs like albumin. Now for the bladder. Some stroke patients can't empty their bladder properly. Others go the opposite way and leak without knowing. Both increase the risk for infection, skin breakdown, and embarrassment. Bladder scans help. Timed voiding routines help. And if you need to use catheters, make sure it's not a long-term crutch without a plan. Protect their dignity every step of the way. And then there's what you can't always see, emotions and confusion. 1 in 3 stroke survivors develops depression, not the blues. Clinical depression that can mess with recovery, participation, and outcomes. Watch for flat affect, irritability, sudden withdrawal, or giving up during therapy. We need to normalize it, screen for it, and treat it early. Delirium's another concern, especially in the hospital. Keep routines consistent. Orient them gently and frequently. Avoid unnecessary meds that confuse the picture. Last but not least, document everything. Document the interventions you did, not just the ones you thought about. Skin checked? Write it. Hobe up during meals? Write it. Spoke to the doctor about new symptoms? Write it. Clear communication keeps your patient safer and your team in sync. Bottom line, sugar? A stroke may have gotten the first word, but we get the rest of the sentence. And that sentence includes no pressure injuries, no pneumonia, no readmission, no preventable suffering. You know what the best stroke rehab looks like? Boring, stable, predictable. That's how you know it's working. Let's keep these patients out of trouble while they do the hardest work of all, healing. Let's talk about what comes next, because the minute that discharge paperwork is signed, the real work begins. The hospital stay is just the tip of the iceberg. What happens in the first few days, weeks, and months after a stroke determines whether a patient regains independence or ends up right back in a hospital bed. That's why transitional care isn't a checkbox. It's a lifeline. Let's start with the discharge plan. A safe discharge doesn't mean stable vitals and no fever. It means, is the home ready? Is there a ramp, shower chair, or grab bar if they need one? Does the family know how to transfer them safely? Do they understand the medication list, the appointments, and what symptoms to watch for? That discharge plan needs to be written in plain language, not just follow up with neuro. But when you leave here, you'll need to see your neurologist in 7 days. Here's the number. Here's what to bring. Now let's talk about follow-up care. Follow-up appointments should be scheduled before discharge when possible, not call when you get home. People forget, people get overwhelmed. The chances of missing a critical follow-up increase when no one sets it up in advance. For some, home health is essential. A nurse to check vitals and meds, a physical therapist to work on mobility, an occupational therapist to help with everyday tasks. These referrals should be in place before the patient leaves the floor. Now, the home environment. A stroke survivor might go home, but if they can't get to the bathroom safely or heat up food, that's not independence. It's isolation and risk. So we assess the home setup. Are there stairs? Are there pets that might trip them? Is the lighting adequate? Is someone there who can help? A home safety evaluation can make all the difference. And sometimes, a short stay in a rehab facility might be a better bridge to home than going straight from hospital to house. Next, cognitive and emotional readiness. We don't just look at muscle strength. Is the patient oriented? Can they remember to take meds? Can they recognize danger signs like slurred speech or one-sided weakness? If not, someone else needs to be in charge of those safety checks. And that person needs to be trained, not just well-meaning. We also evaluate outcomes. How do we know our transitional care plan worked? Did the patient make it to follow-ups? Are they taking meds as prescribed? Did they regain function or plateau? Was there a readmission? If so, why? We track this data not to assign blame, but to improve the next plan, because every discharge should be a learning opportunity for the team, for the family, and for the patient themselves. Finally, we don't disappear. Whether it's a call from a nurse navigator, a visit from a home health nurse, or a clinic check-in, continuity matters. Patients feel safer when they know someone's still keeping an eye out. It's not hand-holding. It's healthcare. Here's the bottom line. A great hospital stay can be undone by a poor discharge. But a thoughtful, well-supported transition, that's where real recovery happens. So before that patient rolls out the door, we make sure they and their family aren't just going home. They're going home prepared. Let's talk about one more topic before we wrap this series, because if you're working with stroke patients, you're going to run into this procedure sooner or later, the carotid endarterectomy. This isn't just a fancy vascular surgery. It's a high-stakes stroke prevention strategy. But when you're caring for a patient post-op, the risks are real, and what you don't catch can hurt them. So let's break it down. First, what is a carotid endarterectomy, CEA? A carotid endarterectomy is a surgical procedure where plaque is removed from the carotid artery to restore blood flow to the brain. It's done to prevent a future stroke, especially after someone has had a TIA or shows significant carotid stenosis. It's usually planned, but the recovery can turn fast if we're not watching closely. Your priorities in the immediate post-op period. Let's start with what matters right away. 1. Airway and breathing. The incision is on the neck. That alone should get your attention. Any swelling or hematoma formation can compress the airway fast. You want to be checking for hoarseness, stridor, tracheal deviation, trouble swallowing, voice changes that suddenly get worse. Keep the head of bed elevated, 30 to 45 degrees to reduce swelling, and make sure airway supplies are nearby. just in case. If you even think the airway is compromised, call the surgeon. Now, not later. 2. Blood pressure control. This is not the patient you let ride high or dip too low. Their brain just went through a recalibration, and perfusion is fragile. A sudden spike can cause bleeding. A big drop can cut off blood flow. So you'll be doing vital signs every 15 minutes at first, IV antihypertensives as ordered, labetalol, nicardipine, etc., watching for trends, not just snapshots. The goal is stable, not kind of okay. Stable. 3. Neuro checks. You're not done watching for stroke just because they had surgery to prevent one. Neuro checks need to be thorough, frequent, compared to baseline. Watch for new slurred speech, weakness, facial droop, confusion, unequal pupils. If anything changes, don't assume it's post-op grogginess. Report it. Watch the neck and the nerves. The incision itself needs attention. Look for swelling, drainage, bruising, signs of hematoma. Also, this surgery puts several cranial nerves at risk. That includes CN7, facial, smile, puff cheeks, CNX, vagus, voice, cough, swallowing, CNX9, spinal accessory, shoulder shrug, CN12, hypoglossal, stick out the tongue. If you ask a patient to smile and they can't, or their voice sounds different, don't assume it's nothing. Document and escalate. Comfort, positioning, and pain. This isn't a high-pain surgery, but the neck will be stiff. Avoid hyperextending or twisting the neck. Support with pillows. Reassure the patient that some soreness is normal, but still assess thoroughly. Complications to watch closely. Hematoma can show up fast, may compress airway or vessels. Look for swelling, firmness, or changes in voice or breathing. If in doubt, call the surgeon. Stroke or TIA can occur post-op. New neuro symptoms always warrant immediate assessment. Cranial nerve injury, swallowing trouble, drooping face, weak voice. Infection usually shows up a few days in. Redness, warmth, fever, drainage. Cardiac events. Many patients have underlying heart disease. Monitor rhythm, watch for chest pain. Discharge teaching. Once they're stable and cleared for discharge, make sure they leave with instructions to monitor for stroke symptoms, guidelines for caring for the incision, a plan to follow up with neurology and vascular surgery, education on BP meds, cholesterol control, and smoking cessation, precautions, no heavy lifting, no straining, and nothing that increases neck pressure until cleared. Final thoughts. Carotid endarterectomy patients walk a tightrope in recovery. Stable is good, boring is even better. Your job is to keep things boring by being on top of the little things before they become big things. Because when it comes to stroke prevention, it's not just what happens in the OR. It's what happens in the next 24 to 72 hours. With you watching, assessing, and speaking up, that makes all the difference.